We appreciate you here. Excited to introduce our two main speakers. So maybe Clint, I'll introduce you first, and then Kathy can just jump right into the meeting after that, if that's all right. But just as an introduction, we have Clint Jones here from AccuReg. Clint is a long-term executive in the revenue cycle space and has played with a lot of new regulations as they come in over the years, and this just is another one to drop in our laps, and so we're excited to have Clint here to join us. So welcome, Clint.
Thank you.
Excited to have you here, so thank you for coming. And then we have Kathy Reep from PYA. Kathy spends a lot of her time doing the analysis and a lot of the consultative work around these new legislative items that seem to pop up over the years in healthcare, and PYA specializes in helping institutions manage a lot of that, everything from accounting to compliance to education and kind of everything in between. But we're excited to Kathy, to have you here and help kind of walk us through the new No Surprise Billing Act and what that means for all of us.
Thanks, Eric. And Clint is going to be my slide mover and join me for questions along with Eric. But what I wanted to do as we get started is to begin with the caveat of don't shoot the messenger. It's not my fault. I did not write this. I merely read the law and then read the rule and am trying to communicate what was in it. So like I said, not my fault. Don't blame me. So here we go. First of all, the No Surprises Act itself was a part of the Consolidated Appropriations Act that was signed into law December 27th. And if we look at the fact that it was signed on December 27th, that becomes a very important date, because we are going to have all of the implementing rules associated with that law published by December 27th. Unfortunately, I'm then going to turn around and say that these rules are effective January 1st of 2022. So the first thing that you can put on why we don't like Kathy is that I told you you might not get the rest of the rules until December 27th, but it's effective January 1. So not my fault. The law was signed on December 27th. As I mentioned, we had our first interim final rule come out on July 13th in the Federal Register. It was an interim final rule with opportunity for comment. Comments due, believe it's September 7th, which is the day after Labor Day, in case you were wondering what you were doing that weekend. Comments are due on the 7th. Now, recognize that there are some provisions in here that are not going to be easy for a hospital or a professional, a physician or a non-physician practitioner to implement. They are not going to be easy. We need a lot more rules, and I'm going to kind of talk about that a little bit associated with this, and therefore I'm now by urging you as a provider to be thinking about commenting on this. I don't know how you can be compliant as of January 1 when you don't even know what all you're supposed to be doing. So that's statement number one. Now, who does this apply to? If you're a hospital, it's going to apply to you, whether a general acute care hospital or a critical access hospital. It's going to apply to providers and practitioners, and I have a very hard time because I often refer to hospitals as providers. Well, in this case, I'm saying from a provider perspective, I'm talking the physician, the non-physician practitioner, anyone who is billing the Medicare program for their services, as opposed to the facility side of the hospital or the critical access hospital. This is also applicable to ambulatory surgical centers, freestanding EDs, and air ambulance. Right now, it is not effective for ground ambulance transport. However, there was a task force that was called for in the law to examine application to ground, and it is has been formed and is beginning to meet. I mentioned in here that it does apply to freestanding EDs. One of the things that you need to be thinking about, because I know where some of the comments are going to go, one of the things that CMS has asked is, should this also apply to urgent care? I think this becomes an issue when it is applicable to an ED attached to a hospital. It's applicable to a freestanding ED. And then we've got these care centers that have big signs on there that say emergency entrance or that say emergence. Or even we have not too far from me, there's one that's on the insurance company that says emergency 24/7. So should this law apply to them? Going to be interesting in terms of what comments come out. I have a feeling those who own urgent care centers are going to say no, and those who have received a surprise bill from them are going to say yes. So that, from a provider perspective, you've got your hospitals, your physicians, others who are applicable to. This is also going to be applicable to your health insurance issuers. Now, many states have laws that impact that govern out-of-network billing. Those are going to continue to stay in place, and you're going to be juggling for some of your payers between state law and federal law. But this is really going to come in and help you as it relates to ERISA plans and things like that that are not covered by state law. There will be a few instances, and we'll talk about them, where state law is going to come in and address payment. I highlighted on this page church plans, and the reason I wanted to highlight church plans is that is directly out of the law, that it does apply to church plans. However, those are licensed insurance products. Those are things like within a particular denomination where they might insure the individuals who work in a church and who their pastors, their others within the organization. It does not apply to faith-based
sharing.
Or I'd say, what, Clint? Give me the term.
The sharing plans where you share the.
Yeah, health sharing ministries. Thank you. Okay. Because they are not licensed insurance products. So if you've had issues with those organizations, you're still going to have issues with those organizations. So going on to the next slide, talk about, okay, so we know who it applies to. What's it mean? The good news, I guess, and I'm going to start at the bottom of the slide, is if you do not participate as a hospital, if you are not participating with a particular payer and the patient presents for non-emergent service and your physicians are not in network either, the law doesn't apply. It will apply if you're providing an emergency service, but if the hospital is non-participating in a non-emergency situation, the law doesn't apply. But let's start then going up. Emergency services. In the case of an emergency service, whether the facility participates or not, and whether the physician or practitioner participates or not, there is to be no balance billing to the patient. There can be no prior authorization for emergency services, and there is a requirement under the law that the payer follow the definition or the guidelines of a prudent layperson standard. This is very important because we've had some payers who have recently information or letters to both their enrollees and to the organizations with whom they contract, saying that if a patient presents to your emergency department, you treat them, and after the fact, we look at the final diagnosis and we decide that the emergency services were not appropriate, it wasn't really an emergency, we're going to deny payment. And you aren't going to be able to balance bill the patient or bill the patient because those are non-covered services. This law says, or actually this was in the rule, the rule says no, a payer cannot do that. They cannot look after the fact at a final diagnosis on a claim and make a determination as to whether or not they were truly emergency services, they're going to have to go back to what the patient believed when they presented to the emergency department, what the physician was concerned about when he treated the patient. They're going to have to do a lot more work than using artificial intelligence to look at a diagnosis after the fact. They're going to have the medical record. They're going to do a more deep dive. Doesn't mean they can't do medical review. They just can't arbitrarily deny without doing that medical review. They get into that question of documentation of presenting symptoms and patient concerns, things like that, that is going to be vital to once, if they do that record review, to protect you. The other thing that I think is a very positive in this rule is what is an emergency and how long does the emergency last? And according to the interim final rule, the emergency period is determined by either the attending emergency physician or the treating provider in the case of perhaps a patient who is seen in the emergency room and either admitted as an inpatient or admitted to observation. At that point is the attending physician who is going to make the determination this is no longer an emergency. And what basis do they use for determining that it's no longer an emergency and the patient can go somewhere in network? That's going to be done by when the patient can leave the facility in a non-medical means of transport. In other words, go by their car to another facility. You have to transport them by ambulance. It is still the emergency period. And the services would have to be covered as if they were in network. So recognize that that is a huge change. And it gives us a lot more clarity, I think, when we are starting to look at a patient who presents and how long the emergency period ends, particularly in light of, okay, we'll pay for the ED, but we're not going to pay for the fact that you admitted them. So giving extended period of time, I think, is really good. So emergency services, law is going to apply, and we'll get into what that means. Non-emergency services, if a patient presents to an in-network facility and is treated by a non-participating provider, the law is going to apply. You're not going to be able to balance bill the patient. That non-participating provider is not, with certain exceptions, and we'll talk about those exceptions. But I know in many instances you will have a patient who presents to the hospital, but one of the physicians involved in the patient's care is out of network. And in the past, the patient has received a balance bill or a surprise bill. Let me clarify, when I use the term balance bill, I am not referring to you billing the patient for their deductible and copay. I am referring to billing them for the difference between what the insurance pays and charges. So that's where we're getting this difference. Under the No Surprises Act, essentially the law says that the patient is not going to be able to be billed any more than their in-network cost-sharing amount. If they go to an out-of-network provider, but they do have insurance, that provider is not going to be able to bill more than their deductible co-insurance that is outstanding. There is the opportunity for some providers to get consent from a patient to bill a higher amount. However, there are also certain specialties that can never get consent. Therefore, they can never balance bill. When you start looking at the list who those providers are, we're dealing very often with those that are contracted with your hospital. Your anesthesiologist, pathologist, radiologist, hospitalists, assistant surgeons, neonatologists, etc. They will never be able to balance bill a patient. They are going to have to accept, talk about how much they have to accept. From the patient, they are only going to be able to bill for deductible and co-insurance. So there will be a set amount or a way to calculate what they will get paid. But if it is, let's say, for instance, I'm going to XYZ hospital, which is in network with my insurance, and Dr. Jones is on staff there, and he is really the best orthopedic surgeon in the area. And I want Dr. Jones to do my surgery, but I know he's out of network. Because I am going to him, he is telling me he is out of network. He can actually come in and say, I'm out of network. If you really want me to do this service, you're going to wind up paying more than if you went to an in-network surgeon. And I can say, Dr. Jones, I want you to do this. I don't care. I'm more than willing to pay. Make sure that, Clint, you understand I will become a bad debt, but I could tell you that anyway and sign that I will pay. But just wanting you to know, a patient with their surgeon has the ability to do that. They couldn't do that with their anesthesiologist or with an assistant surgeon who Dr. Jones brought in. So recognize that there are limitations on who can balance bill. From a provider perspective, yes, Eric.
Just real quick right there. So question for you. So there's lots in the language around these consents and what should be in there and what shouldn't be in there and who should get it and who shouldn't. Are there examples out there of sample language around what should be in these consents?
Absolutely. And again, don't shoot the messenger, but there are several consents. First of all, I have as the next bullet that there is a requirement that you inform your patients of caution protections. There is a model notice. Essentially, you're going to post that on your website. You're going to print it, probably hang it next to your HIPAA sign, and you're also going to make that notice available to your patients either electronically or by mail if they have insurance. There is a 4-page consent that would be gotten, and that is available on the CMS website. 4-page consent is what would be completed in the case of a patient being willing to go out of network. And we'll go through in a minute what's in that consent, but it is very, very lengthy. And recognize that one of the things you're going to have to include in that 4-page consent is an estimate of what your charges are going to be for this service. And it is going to include not just the overall cost of of this service is so much. It is a detailed, including service codes, item descriptions, and the charges for those codes. It is not just a lump sum $20,000. It is 3 days room and board, this, and this, or physician perspective. These are the things I'm going to be doing. You know, essentially think of a bill, but a bill before you ever provide services.
Hey, Kathy, I know we're only on slide 3. I'll make this really quick, and it can be a yes or no question. But just to clarify for the audience, we're not talking about bundled billing here. What we're talking about is in-network and out-of-network. So is it true that I can go to the ED, spend 8 hours there, be seen by a hospitalist, anesthesiologist, a lab, and when I get home, I can get 14 different bills as long as they're all in-network, right?
Yes, you can get 14 different bills as long as they are all in network.
It doesn't all have to come from the hospital. That's my point.
That is correct. Absolutely. Going on to the next slide. Okay, let's talk about the advance notice just so that you're familiar, because we want to allow some time for discussion today. The advance notice, that the consent that you're going to get from the patient to balance bill them, is, first of all, you've got to look at whether or not the patient has the capacity to consent. Very, you know, as the example they give in the rule, I'm sorry, but it's kind of silly. You're in the middle of surgery and the physician identifies that a different surgery is needed and a different surgeon needs to come in to do a specialized technique. No, you don't have to have consent to do that. And to, you know, you aren't, I mean, you can't get consent at that point because the patient does not have the capacity to consent to a service. In the middle of a major emergency, again, do they have the capacity to consent? You're going to have to clearly explain, and if you read the draft that CMS released, you're going to have to explain that you're going to be billed at a higher out-of-network amount than you would if you went to someone in network. You're going to have to make sure that that consent form is in a plain language. CMS did post their consent and had commented up through last week. So plain language. It must be accessible, and both for those who have hearing impairments and also language access. The rule says that it must be translated into the 15 most common languages within your area, and then you must make it available to any other folks speaking other languages through interpretation. So recognize you're going to have this translated into a number of different languages. One of the comments that I saw recently pertaining to this was asking CMS to actually translate into the 15 most common languages in the country to help relieve the burden on the providers. Timing of the notice. This isn't so good, okay? First of all, if the service is scheduled in advance, the patient is willing to go out of network, you're going to have to give them the notice 72 hours prior to the date of service and have them go out of network. If it is a same day appointment, you've got to have them and have them sign the consent 3 hours in advance of the appointment. I think that's very difficult to do, and I think it's worthy of a comment because I'm not sure what you're going to do with the patient who is sitting there in your lobby, and maybe under COVID, they are sitting in their car until you tell them they can come in, and they haven't eaten because they came in for a 9 o'clock appointment. We now know they're out of network. They want you to do it anyway. We're sending them somewhere to sit for 3 or 4 hours. I don't know how well that works. So I think it's something worth discussing in comments, but 3 hours in advance of service for same day appointments, according to both the rule and the law. The notice is going to have to inform the patient if there are any restrictions related to prior authorization, care management, things like that. Is it an instance that before this service can be done, you have to have, before I can do knee replacement, you're going to have to go through and have injections and outpatient therapy to make sure that surgery is really warranted. All those things are going to have to be communicated to the patient. You're going to have to include, as I mentioned before, a good faith estimate of the charges for that service. Think about how you're going to itemize that. And you're also going to have to give the payer notification that you have a consent, and they must be given, the payer must be given a copy of that signed consent, including the estimate of charges, and this has to occur prior to services being rendered. Now, that just got really difficult because I'm not sure what methods you have to send a signed document, 4-page document, to the payer with that estimate of charges, and for them to then communicate back with you, which we'll talk about their communication back in a second. But we don't have an electronic transaction standard to allow you to send this. I'm not real comfortable with the idea as of faxing it. So go on to the next slide.
Well, hang on just a sec before you move on.
You can stay.
Say what?
Go ahead. We can either stay on this slide or go back, whichever one you need.
Why don't you go back one just for a second? So on this slide, right, we go down, you have the whole list here of things that need to happen, right? So there's the time limitations and so on, but then at the end of the day, we have to pull together kind of a whole packet of information for this visit, right, for this encounter, and then that needs to get sent to the insurance company. Is that right?
And this is going to happen prior to the services being rendered.
Right.
because
so
you're going to have to do this in order to tell the patient what they owe.
got it. So there's a ton of stuff there. And so maybe let's just take a pause here before we jump into the next area, and even let's open it up to attendees here for a second. We've just thrown a ton of information out to everybody, right? And there's lots of nuance here of what has to come together. What questions do folks have here? You can throw it in the comments, or you can unmute yourself. This is a small enough group. What questions are out there so far?
Thanks, Eric. Hey, this is Brooke. I do have a question regarding our out-of-state Medicaids. So there's some nuances with the Medicaids. Normally, we typically wouldn't bill a Medicaid patient. However, we do have some out-of-state Medicaids who, because of some state requirements, that there are certain carve-outs or certain things that they weren't covered because they came out of state. What does that look like with this new policy with these types of plans?
Medicare, Medicaid are both excluded from this because most of those programs already have prohibitions on balance billing a patient. Now, you said there are carve-outs. And that to me means these are services that are not covered under Medicaid.
Correct.
All right.
Well,
this does not apply in any instance. Like, for instance, let me give you a simple. Patient comes in to deliver a baby, but does not have newborn coverage. Okay. There's no balance. I mean, this doesn't apply because there is no coverage for that person. They couldn't have received services in network because they have coverage for it. That out-of-state Medicaid or even some in-state Medicaids, when there are things they don't cover, those are not covered by the law because they are truly not covered services.
Okay, I just wanted to clarify. Thank you.
Okay, sure.
Maybe while people are thinking through this a little bit more for a second, Clint, the other day you gave a great example of kind of from beginning to this point of what that kind of looks and feels like. We walked through a sample scenario. Do you recall that and want to run us through that maybe?
Yeah, it was actually almost exactly what I just asked Kathy a minute ago. It's just the idea of, if I go, I think this is the one you're talking about, if I go to the ED and I get poked in the arm by LabCorp and a hospitalist group sends an ER physician over to see me, and I've got, a contracted PA and who knows what else, an anesthesiologist and all that. At the end of the day, if all of those, which they typically are out of network, I'm only going to get one bill from the hospital. And
you're going to get one bill from the hospital, but you're going to get a bill from all the others.
Not if they're out of network. No, that one I clarified that they're out. But if they want to do an in-network price, they can bill me.
Well, they are going to bill you your out-of-pocket liability. In other words, if you have, Clint, and maybe I didn't understand your question the other day, if you have an outpatient, if you have insurance, you're going to have a deductible copay on the hospital bill and on the physician bill, you're going to have to pay your out-of-pocket liability to your physician bill as well.
Okay. Yeah. So like on mine, on my particular plan, I don't have any deductible for ED. I have a $250 copay for. Oh, and this is the example. So I said if I'm there and I don't get admitted, I think that's what the one I was saying. So if I do go in, I pay $250 to the hospital, and I don't get admitted, they send me home. Then the only thing I can get billed after that would be from any ancillary services would be what?
You aren't going to have anything else that I can think of.
If they're out of network, right? Okay.
If they're out of network.
Right.
Yeah. Because you've paid you've paid your ED liability.
Right. Exactly. Yeah. So there's a lot of nuances to every plan, and it's going to look really different. Even if you already have an estimator or good eligibility, there's still going to be a lot of work to do here.
And that estimator is going to come in, be very important for that idea of developing that consent where you have to list that detail of the charges, the expected charges. Let's go on to the next slide, and then we'll have time for questions as we go along too. how do we determine what the patient owes? Unless you are in an all-payer state like Maryland, or in either, Vermont and Pennsylvania, where their state laws define patient liability, we're going to be dealing with a qualifying payment amount. It's a new term we're going to have to get used to, a QPA. You have sent the consent to the payer with the fact that here's an estimate of my charges and here's what the patient's having, et cetera, et cetera. They are going to use that. They're going to generate a qualifying payment amount, which is established as the payer's median in-net rate for the same service in the same market. So you might not be contracting, but these other 5 guys might be. So what is their median in-network rate? And making sure that you recognize that to calculate a median in-network rate, they're looking at, I have a payment rate with Dr. Jones of $2,000. I have a payment rate with Dr. Wixom at $5,000. However, Dr. Wixom has only done 1 case and Dr. Jones has done 25. Okay, so I'm going to have to multiply by 1 times the 5,000 and my 25 times the 2,000, and then divide by the total volume to come up with my median in network rate. Dumb question, but I'm going to throw it out right now. Anybody have any idea how you're going to validate that the median in network rate that comes back from the payer is accurate?
Because we trust payers.
Just thought I'd throw that out. They're going to begin by using 2019 rates. They're going to trend them forward. However, they will eventually be using more current years. Now, I'm going to throw this out and just let you know that I have heard that in some states, we have some payers who are going to providers, both facility and practitioners, with whom they have a fairly high contracted rate. They are asking them to lower their rate. And if the provider says no, they are saying, well, then you might just have to be out of network. They're ceasing negotiations. Therefore, we're going to get into a situation where they are out of network. They're going to be either having to go to arbitration or accept a median, or, the amount that is offered by the payer. Patient's liability is going to be based upon that median in network rate. We could be dealing with some games in order to reduce what those who currently have high rates might be forced to accept lower rates going forward. So something to look for if you have payers who are suggesting that you agree to a different lower reimbursement rate. So you have sent the consent. They have calculated a qualifying payment amount, and the payer is going to have to send to you an advanced explanation of benefits, an AEOB. You're used to getting those after the fact, but now you're going to get one prior to services being provided. And that AEOB is going to address patient liability, what they're essentially saying they will pay, where the patient is, and their cost sharing, any rules related to prior authorization. And I love this, that they have to include a disclaimer that this is just an estimate and subject to change. And also with that AEOB, which will go both to the payer, to the provider and to the patient, they are going to have to include a list of all in-network providers that are able to furnish the service within that market, within that area. Just want you to know this is what you're going to have to pay if you go out of network, but if you decide to go in network, I can lower the rate. Excuse me. The next slide.
Kathy, a couple questions on the AEOB. So you mentioned that it has to happen prior to service being rendered. Does that mean the hospital has to delay services until it receives the AEOB?
In a non-emergency situation, yeah, because otherwise you don't know patient liability.
Okay. And
Eric, let me say one thing about that. Recognize from a hospital perspective, or for hospital or practitioner, this is only when you're out of network and you have a consent, not going to be in an emergency situation. So you need to look at how frequently do you have out of network patients, and recognize that for those patients, you are going to have to go through this process.
Excellent. Thank you for clarifying that. And with those then, so the AEOB goes out, is that going to the hospital and the hospital has to get that to the patient? Is the insurance?
Yeah, I think it's going, my understanding is it will go to both. This is one of those things. Thanks for raising. Remember I said we've got 3 rules. We've got the first one. There's a rule still to come out on the AEOB. And there is a rule still to come out on arbitration, which I'll talk about in a minute. But are we going to use, what kind of a electronic transaction standard are we going to use for that AEOB to be generated? Same way we need a way for you to communicate your consent and your charges to the payer, they need a way to communicate the AEOB. Doing 835s and 837s prior to services being rendered? That will be confusing. Kind of, sort of. Go ahead. Okay, under the law itself, now this is the law as opposed to the interim final rule. I think Eric is going to share with you all the slide deck, and you can see from the heading on the slides, some say IFR, advance notice, etc. This one and some of the others say No Surprises Act. This is law versus reg. This is where we still need regs coming out. According to the law, the payer is going, once you submit a clean claim, no, we don't have a definition of that yet, but once you submit a clean claim to the payer, they are going to have to either pay or deny within 30 days of billing. Okay, that's good, 30 days. Granted, if you're out of network, what are they going to pay you? But they're going to calculate some, and they are going to, and you are going to either be happy with that payment amount or not. Once you receive that, under the law, you have 30 days to negotiate with the health plan for a different amount of money. You want more. So you're going to negotiate with the payer. At the end of that 30-day period, you have the opportunity to go to a mediated dispute resolution process. Think baseball, think arbitration. However, you only have 4 days to make the decision to do that. You are going to have to trigger mediation within 4 days of that end of the 30-day negotiation period. So very short turnaround. And I think it becomes very tight in terms of the processes you put in place in your business office in terms of, we are hitting day 28 or day 25 on our negotiation. We need to be prepared because certain information that we're going to want to share when it comes to going to arbitration. We don't have the implementing rules yet related to the arbitration process or even who the entities will be. The law says that they have to be independent, unbiased, and have no affiliation to provide payers. So I'm not sure who they are, but there will be entities that are identified as the arbiters. Don't know if this will be done at the state level, if it will be done regionally, if everybody is sending something up to Baltimore, what's going to be, but some way or other, we are going to have these independent entities that will be deciding your payment. There is no minimum amount of money that you can take to arbitration, and you do have the ability to bundle claims that are for a similar issue, same payer. Going on to the next slide, let's talk about the arbitration process. You're going to go to arbitration, and this is where I say, you know, there needs to be a time frame in there where if you think you're going to wind up having good arbitration, starting to get your ducks in a row to figure out what you're doing. You're going to have to provide, you've got 4 days to initiate the IDR process. then within 10 days of initiation, information you've got to provide to the IDR entity. You are going to have to say, this is how much I want to be paid. Payer is also going to say, this is how much I think I should be paying. The arbiter is going to make a decision between those two amounts. They can't say, let's split the difference or anything like that. It's the payer's amount or the provider's amount. No choices in between. The one thing that is good is that the law does say they can't look at public payer rates, so they can't look at what Medicare or Medicaid pay. That can't be taken into consideration, nor can a provider's charges. So they can't look at your charges. They can't and say, you know, you can't ask for charges essentially, nor can the payer offer Medicare. Those are excluded. So they're going to you're both going to come up with rates. Now, there's some information that's going to have to be provided or is recommended to be provided to the IDR entity. The payer is going to have to provide information about their median in-network rates. Remember, they use that to calculate patient liability. Now they're also going to be providing that to the arbiter, because if they are offering you more than their median in-network rate, or what they say is their median in-network rate, what's the arbiter going to say if it's, I'm offering you more than they're paying other people within the market, you know? But they are going to have to provide that information of their median in-network rate to the arbiter. They are also going to have to, I mean, you are going to have to provide as a provider any information about your training or experience. Think about this more from the physician practitioner side, training and experience that makes you have a higher rate or should have a higher rate. From a provider or facility perspective, provide information related to the patient acuity and the complexity of the care provided. Why is it different from the typical patient? And if I was the facility, I'm also going to be providing information that I'm a teaching hospital. I have extremely high case mix compared to the other providers within my market. And here is an example of the specialized services that I provide, etc. I would be providing them as much detail as I can to support your rate. And then the entity is also going to take into consideration any whether or not there was good faith to come up to resolution. Going on to the next slide, just very quickly, the arbitration process has to be concluded within 30 days, and then after that day period, the payer has 30 days to make payment. And the payer has to pay the facility, the provider. They cannot pay the patient. That has been an issue in the past where they have sent the money to the patient and then you've still fought to get your money. That cannot be done. It has to go to you. But recognize that if you lose at arbitration, you are going to have to pay the cost of arbitration. And I don't have a clue as to what that's going to be, but the losing party will pay. If you were to reach a resolution with the payer midway during arbitration, you're going to split the costs because you've already incurred costs. But normally, if you go to the end of arbitration, it's going to be on the losing party to pay. There were a couple of other provisions included in the law itself. If we go to the next slide. Gag clauses, a lot of people did not post their transparency rates, their payer-specific negotiated rate when they were required to earlier this year because they said we have language within our contracts allow us to disclose the information. Under the law, gag clauses are prohibited. You can't have that in a contract. Under the law itself, there was requirements related to providing that good faith estimate of scheduled services both to the plan and the patient. And the law called for you to provide diagnostic codes for all items and services to be included with the estimate. I want to clarify that the interim final rule has replaced the word diagnostic codes, which to me, I'm starting to think ICD-10 and things like that. They have replaced it with service codes. And when I start thinking service codes, I'm thinking CPT, I'm thinking rev codes, things like that. So the that CMS or HHS has created calls for service codes, not diagnostic codes. I think that would be a lot easier for you to produce. So this is a variation in terms of implementation. Very quickly on the requirements related to the plans themselves. They have to develop an online price comparison tool that would actually allow a patient to go in and say, I have Blue Cross options, and I want to see what my payer is going to pay for provider A, B, C, and D within my community for that service. So you should actually be able to go in and look at not just what they pay, but they've got to have a comparison tool out there, which is a little different than the current law for them that goes into place in January. They are also going to be required to maintain an accurate provider directory. And if a patient relies on a directory that is not accurate, and they have a copy of it, they're going to have to be covered as if in network. Going to have to move to having sharing information on the member ID card. Two more slides very quickly. The things that are missing from the interim final rule, we kind of talked about. We don't have details of the process. We don't have a lot of information about how we communicate the good faith estimate or how that advanced explanation of benefits is going to be generated. And we need more detail on the provider directory issue. Comments, as I mentioned before on the last slide, comments are due September 7th. And some of the things that I think are important for providers to include comments. First of all, should this apply to urgent care centers? I think it's something that's worth thinking about. Is this an area of concern or complaint? And the big issue to me is I personally think the need for a new HIPAA transaction standard in order to do the communication that we need to do. I've given you there the kinds of information that we need to have a standard to be able to help us communicate. Anyone who was around with the development of under HIPAA, the 835, the 837, the 271, the 272, you know that this wasn't an overnight process. It took a number of years to get those in place and to get them approved and through all of the approval agencies. I don't know how that happens by January, and I do think that is well worth commenting on to in response to this rule. How do we do this? And even with that said, I'm also going to say I don't look for a lot of delay. As providers, you've been in the middle of COVID. You're still in the middle of COVID, but I don't look for a lot of delay in this because of the patient or the consumer protections that this is focused on. So there needs to be perhaps not a delay in compliance, but a delay in enforcement. And that maybe you should include that in your comments, that there should be a delay in enforcement until all the rules are out. If you are compliant, it is a civil monetary penalty of $10,000 per occurrence. So I can tell you got to be compliant January 1, but don't force it until everything is out there. So that would be my comment. Last slide is our contact information. And with that, I'm glad to take some questions, as is Eric and Clint and everyone who are going to help me out.
Absolutely. Kathy, thank you so much. That was absolutely incredible to pull all of that craziness together into one presentation here. We really appreciate it. I would love to hear from the attendees. I mean, I've got some questions I can go down, but I'd love to hear from those attending. What are you worried about, right? What can we help with? What questions do you have for Kathy or from Wix Corp and AccuReg around things that we maybe be able to do to help assist as we try to navigate this as an industry? If you're asking a question, you're on mute right now.
Eric, this is Brooke. So probably, I mean, as far as help, probably just some of the literature and instruction on verbiage. Just, I mean, it seems pretty clear, but we just want to make sure at the end of the day when we're getting all this stuff posted as far as notifications, maybe some help with that would be nice.
Absolutely. So this is a recorded session, and we'll make the recording available for you for reference later. We'll also send a copy of the slide deck out, and then we'll try to include some references in there maybe to where those consents, the sample consents are, and some of those elements, so we can send you a whole packet of information.
But Brooke, the one thing I would say is don't go print up a lot or make your signage or get things posted on your website or get any translation done, because these were produced for comment. And comments were due last week. I wouldn't spend, I take a look at what they say, what they're asking for, but recognize that there's going to be another version that will be released before the end of the year.
Okay, thank you.
Great question. Thank you. Any other questions from the group here?
I'm going to ask a question, and this is really for Eric and Clint and this group. And one of the things we talked about when we were planning this session was rules. We know what we have to do, but how do we, where do we put responsibility within our organization? And so I think that might be something, if y'all are in, to maybe even think about future calls where people discuss, where are you doing this and how are you verifying this, and what dialogue have you had with, I mean, I'm sorry, but from a hospital perspective, have you gone and anesthesiologists that they aren't going to be able to bill for charges anymore, that they're going to have to accept? They're going to have to accept from the patient what the insurance company says is their deductible and co-insurance. And from a payer perspective, they're going to have to either accept what the insurance company pays or go to arbitration. Mm-hmm. And at the same time that you have that communication with your anesthesiologists and your hospitalists and others, you're probably going to have a comeback with, well, how are you going to make me? And I think those are things that I think it would be good to keep in communications, keep in dialogue with each other in terms of how you're dealing with these things. I have not seen a lot of comment yet from those groups who are not going to be allowed to balance bill saying, oh, this is a great law, I'm glad it's implemented. But I don't know if they're paying attention to it yet or not either.
Yeah, the strategic relationships and how all these disparate parts come together on this are going to be really interesting, and certainly something that as an industry we need to be mindful for, and proactively looking at those conversations. I know one of the things that I look at as we look at these incoming rules that we're going to have to follow. Obviously, the estimations that we're providing are going to need to change a little bit to be able to meet these rules. Being able to get those consents out and get them signed and filled out in a timely fashion and back in and collecting all of that is going to be an issue, regardless of how we even get it to the insurance company. Just purely bringing the patient along the fold with all of this. I try to look at this rule a lot from the patient perspective of what does this look and feel like from the patient, and it's just craziness, right? The patient's not going to understand why any of this is happening, and they're going to be super confused about it. And so how do we engage the patient in this process and move them along? How do we help them understand well, here's the estimate and here's why we came up with this estimate. Who's producing that estimate, right? Because if the patient's talking to the scheduling team and they're trying to put this together, they're not going to have the ability to produce that estimate on the phone because they're not going to understand the coding background enough really to pull that together. And then getting the patient to sign the consent, understand what they're signing, collect that, and do all of that in a timely enough fashion to get it off to the insurance company so that they can then produce that AEOB.
Absolutely,
response,
absolutely.
right? And so there's some key critical touch points with the patient that we're going to need to be cognizant of as well along this path.
Absolutely. We've got to define workflow. We've got to define who's doing what. I think there's a lot that we've got to deal with.
Agreed. All right. So in the last 2 minutes, Kathy and Clint and I have all asked each other lots of questions. I'd love to hear any final thoughts from the group. No? Clint, anything that you'd like to add as we start to wrap up here?
Just one clarification. Kathy, I heard at one point there was a November 1st deadline, but that's not right, is it, for the final rule?
There is no.
Okay.
No.
Okay. I'm good. We covered a lot.
Typically, comments are the 7th. Typically, they sit on comments for about 60 days before they publish a final. But because it is an interim final, it will go into effect January 1, even if they don't do anything else.
Yeah.
All right. And last comment, right? So if there, Kathy mentioned comments and comment submission. If there's concerns here and things you want to express, talk to your congressman, right? That's where a lot of this comes from. You need to reach out and let them know.
The only way you're going to get delay is by going to Congress.
Right.
Department of Labor, this was a joint rule by HHS, Department of Labor, IRS. You are going to have to go to Congress to get a delay.
Right. So knowing that the final rule will probably come out just after Christmas and you'll be accountable for it for New Year's, that gives us a week to pull all this together at the end of the day and make it happen. And so certainly reach out to your Congress representatives if you have concerns around implementing that and trying to get some delays in the monetary penalties there. But certainly something that regardless of what happens there, we need to do what we can internally to get ready for it. And I know certainly PYA, AccuReg, and Wix Corp are committed to do whatever we can to assist your institutions along that way. So over the next few months, we'll continue to send out updates as we have it. And certainly if there are things that we can provide to help assist you with managing all this and staying compliant, we're committed to do so. So we appreciate everyone's time with that. Kathy, you did an incredible job. I feel like I just kind of rode your shoulders through this. So thank you so much.
Anytime.
Clint, thank you as well. We appreciate everyone coming together for this. I'll send out the information post the meeting. And then certainly if there's follow-up questions, please feel free to send it to any of us here. We're happy to help answer it.
Thanks,
Take
everyone.
care.
Thanks so much.
Everyone. Take care.
Bye-bye.
Bye.